Welcome to Learning with Logan. Today's episode is brought to you by the University of Missouri Parking Service, charging you hundreds of dollars for uncovered parking.
Hey guys, thanks for listening. Welcome to Learning with Logan. On today's little episode, we are going to be talking about traumatic brain injury, which most of the time for the rest of this podcast, I'll probably be referring to it by TBI, which you guys should be familiar with, as well as its relation to our profession as a whole and to dysphagia in these patients. So I'm going to start by just talking about a couple types of TBI and giving you guys a little bit more information about traumatic brain injuries. So there are two different classifications of TBI. So you can either have a patient with a penetrating TBI or a closed head TBI, and those are pretty well what their name stands for. So a penetrating TBI is where the skull has been comprised by a foreign object. So what comes to mind instantly for me would be like a gunshot wound, and these also are the cases with the highest morbidity and mortality rates. So chances are, if you have a penetrating head wound, you're likely to have a more severe case. Whereas a closed head injury, there's nothing that's penetrating the brain or the skull. So this could be, for example, a car crash where there's a lot of like back and forth motion. Or, for example, you could have a patient who came in who has been playing football and has had like a hard hit, and they have a closed head injury. The CDC did post a little graphic about the top 6 reasons of traumatic brain injuries, and the number one with 28% was falls. And when I think about falls, I think about our older population. So I would keep this in mind whenever you are thinking of TBIs. This isn't going to be, a certain age group. It could be anyone from an infant all the way to, our older adult population. Now I'm going to move into traumatic brain injury symptoms. And this is where we really need to be paying attention. If you get anything from my presentation today, this would be, a primary piece of information. So there's two different types of symptoms. We have primary symptoms, and these are what happens at initial impact. So it could be bruising, bleeding, whatever is going on physically inside of the skull. That's our primary symptoms. And then we move on to secondary symptoms, which is kind of where we move into the treatment. So our secondary symptoms are anything that are following the impact. So I'm going to go through some different subsets of systems, and let's really make sure we listen and think about how these relate to both treatment and assessment, especially assessment because, we have these standardized tests where they give us specific instructions on how to administer the test, but these aren't fit for every single perfect patient. We may have a patient who has a TBI and has lost their hearing of their right ear, for example. And you need to keep these things in mind as we are planning treatment and assessment. So just really keep that in mind. So, first, we have physical symptoms. This could be major headaches, this could be fainting, seizures, anything physical that's happening with our patient. And these, there's no perfect physical symptoms that are going to come with every patient. They are going to vary. And then next we have our sensory, kind of like I had mentioned earlier. These would be, light, sound, touch sensitivities, hearing loss, visual field changes. And we definitely need to take those into account during assessment and our treatment. Behavioral changes is also a huge, pay attention situation. They could have mood swings, they could have anxiety, depression. I mean, think of how much a TBI can change the lives of a patient and the patient's family. So, kind of go in with a faint heart, expecting possibly some behavioral changes, and then cognition. If I could bold my voice, I would be. So, just to name a few cognitive changes, we could have attention deficits. They may only be able to listen and follow directions for just a short amount of time before needing a break. It could be memory loss, ranging from short-term memory loss to long-term memory loss. I mean, it's going to change your treatment if you walk in and they don't even know their own name. So that's a major red flag. Also, the patient's ability to plan, set goals, follow directions, problem solve. I just think back to our assessments and how a lot of them are not set up for a lot of cognitive decline. So let's keep that in mind. And then also our speech and language, just a little bit. I'm going to continue to talk about this. This could be dysarthria, apraxia, reading comprehension deficits, aphasia. That's all within our realm. So let's keep all of those in mind as we continue on. And then another piece of information I thought we should know, especially when talking about TBI, if you are given an intake form of a patient, there's a good chance it's going to talk about the Glasgow Coma Scale. And what this scale is it represents the severity of a traumatic brain injury, and medical professionals use it. So we won't be the ones who, give the score, but we may be looking at this. So the scale goes from 3 to 15. And remember that 3 is the most severe and 15 is the mildest. I personally think that should be switched, but it is from 3 to 15. Anyone who scores below a 9, so from 3 to 9, is considered to be in a coma state. So those are very, very severe cases. Okay, so shifting from basically an overview of dysphagia, we're now going to be talking about to TBI and dysphagia and their tie. So, as we've discussed in class, nutrition is essential for everyone, literally everyone, especially for those following a TBI, where they need adequate nutrition and hydration to fuel their bodies to help themselves heal. Because, after a TBI, they're in a major state of needing to heal. So, relevance, I didn't realize how relevant dysphagia was to TBI. Um, it is said that 37.5% of patients with TBI aspirate, which is a huge number. I mean, 37%, that's almost 40% of patients that you will see. So as soon as you walk in there and see your client for the first time, already be looking for those signs that we've talked about in class, having a fever spike after they eat, coughing a lot. Those are things we can constantly be putting on our clinical hat and, taking note of all of these things. Um, the most common swallowing problems for those with TBI or are prolonged oral transit. That is seen most of the time for the ones who are, um, in that acute phase right after their TBI. Um, a delayed swallow reflex, and then also and then it moves on to more issues in the pharyngeal stage of their swallow. Those patients who are in the early stage, like I had mentioned, have a higher risk for dysfunction in the oral phase. Some of that's thought to have a tie with their cognitive declines. I mean, if you have memory problems and you put something in your mouth, they may not remember, how to make a quick swallow or how to chew properly. So, like I said, just have that clinical hat on and be looking for these things. On a more positive note, um, the duration of dysphagia in these TBI patients it has been seen to be relatively short. So it says from 17.6 days to 2.5 months. And I know for us, 2.5 months may seem like a long time to have swallowing issues. But, when you look at dysphagia as a whole, this is a pretty positive number, which makes me move on to our assessment and our treatment for that dysphagia. So for assessment, I think our best option here would be start with a screener. I personally like the 3 ounce water test, especially if you have a client who has some cognitive or speech um, issues that they're not able to tell you where they're struggling. They don't have the ability to say it hurts when I swallow. I'm not able to eat, this type of food. So you could start with a 3 ounce water test and just watch, write notes and just see what you observe. And if you do have any concerns, then obviously we can move into a full evaluation. Again, I have noted here to keep in mind the cognitive defects and all of the other symptoms that we talked about earlier, the sensory symptoms, the behavioral symptoms, speech and language, all of those as we're giving directions during an assessment. You may have to use a more multimodal approach. You may have to write some of your directions. You may have to, come up with some unique ways to get your points across to have the best assessment possible. And then moving back to kind of how we have a shorter duration of dysphagia that has been seen, I think a great way to, help them through this phase is with some compensatory strategies. All of the ones that we talked about in class would be great. The postural changes, which is the chin up, chin tuck, head turn, head tilt, side lying, especially if they're in a hospital bed, the side lying could work. Sensory stimulation, you also could modify the bolus, give them slower presentation, make it thicker, whatever you need to do. Additionally, keep in mind that if they had memory defects and you told them to take 2 swallows after every, bite, they may not remember that. So you might have to use some family education or caregiver education and also use a multidisciplinary approach. So get the nurses on board, get the nurse techs on board, the PT, OT, whatever you have to do to make sure that they're following your instructions so that we have the safest plan of care. Also, you can talk to the client's dietitian to make sure that we are meeting nutritional needs, any allergies that might be present so that we have the best plan of care for our patients.